Hello, everyone, and welcome to the UVA Medical Center Hour. I'm Justin Mutter, Director of the Medical Center Hour, which is a program of our Center for Health, Humanities, and Ethics. We are excited to bring you today's event in partnership with the Department of Medicine and the Division of Infectious Diseases and International Health. The annual Hayden Farr Lecture in Virology and Epidemiology marks a critical opportunity to pause, especially in the midst of our ongoing pandemic, and to think together about the past, present, and future of the public's health. Today's session is offered in Zoom webinar format, and we welcome our many attendees, both inside and outside of the University of Virginia. And when the time comes for discussion and questions following today's lecture, we invite you to submit your questions via the Q&A tab at the bottom of your Zoom screen. Information about continuing education credit is also available on the opening and closing slides, which you will see toward the end on your Zoom screen. It is now my privilege to welcome to our Medical Center Hour stage our moderator for today, who, like the distinguished speaker he will introduce, really needs no introduction. Dr. Costi Sifri is Professor of Medicine and an endowed chair in Infectious Diseases and International Health here at UVA. Known well to many of today's participants across UVA as an extraordinary leader in infection control both before and during the COVID-19 pandemic, Dr. Sifri is also the medical director of UVA's Immunocompromised Infectious Diseases Program. An internationally recognized scholar in molecular epidemiology and the transmission of multi-drug resistant organisms, we are honored to have Dr. Sifri as our moderator for today's event. Costi.
Thank you, Justin. That's very generous of you. So this is truly an honor and pleasure today. So I'd like to start by saying that I can't think of a better speaker than today's speaker for the 10th annual Hayden Farr Lecture. Briefly, Fred Hayden and Barry Farr, whom this lecture series acknowledges, are leaders in both virology and epidemiology. Fred is joining us today, and as many of you know, Barry Farr passed away several years ago, but a leading voice in hospital epidemiology and infection control. The lecture today is being presented by Rochelle Walensky, who needs no introduction as the director of the CDC, and I'll talk a little bit more about her bio in a second. I'd like to take a moment, though, first and acknowledge Dr. Jack Gwaltney, who has made this lecture series possible, and a special thanks and shout out to Cameron Webb, who helped facilitate this conversation today. So thank you, Cameron. So Dr. Walensky, as I said, needs no introduction, but a short discussion of her biography. So Rochelle attended medical school and did residency training at Johns Hopkins University. After Hopkins, she joined the Mass General Hospital and Brigham and Women's Hospital for ID fellowship training, where she also obtained her Master's of Public Health at the Harvard School of Public Health. She stayed on afterwards, joined the faculty at Mass General, and quickly ascended the ranks, becoming a world's expert in using really evidence-based policy and practice to inform HIV care, from HIV screening and testing to questions around PrEP and a whole host of other issues during her career. In addition, she was an incredibly vocal, passionate advocate of compassionate care of HIV patients, and also I think just really a notable standout in understanding the issues around gender and equity in clinical care as well as clinical research. In 2017, Dr. Walensky was named the director, the chief of the infectious disease division at Mass General Hospital. And as you know, in late 2020, was asked by President Biden to take the helm of the CDC. She was an important and leading voice in the early care of patients during the COVID pandemic. Of course, Boston was one of the cities that really was first impacted by COVID, and her experience as both a frontline clinician and help leading a world-renowned ID program through the early stages of the pandemic were instructive for all of us who face those same challenges in a short number of months. In addition, through the pandemic, stepping outside of clinical care, she was an important advocate of understanding how to provide higher education and have students return to classroom through modeling systems, modeling studies that helped inform how college students could return back to in-person instruction at a time prior to the rollout of vaccines and at a time when most people had not yet encountered COVID. It was really just an absolute honor and pleasure to have Dr. Walensky join us today. She'll be providing today's lecture, and hopefully at the time we'll have a little bit of effort, a little bit of time available for a Q&A. Rochelle.
Great, thank you, Costi. Let me first, let me say what an honor and privilege it is for me to give this Farr lecture and for the people that it honors, and how so much of science is standing on the shoulders of greatness ahead of you. And so I recognize that I'm doing so in the context of this lecture. I do also want to let folks know that sometimes great things happen in tiny little fellows rooms, and one of those great things is I had the great privilege of meeting Costi during my fellowship and maintain some really great friendships and really great colleagues and collaborations. So this is really one of my favorite audiences, and that is sort of home to my academic audiences, which are known and familiar to me. And really, again, what a great pleasure it is for me to be here with you. I thought I would just spend the next 50 minutes or so talking about sort of CDC's action-oriented response to public health and some of the things that I look at every day, the data that I look at every day, and sort of maybe giving you a window into some of the moments, some of the hardest moments for this pandemic for me, and some of the challenges and decisions that we've had to make at CDC. So one of the things I look at every morning, these data had been coming in on a daily cadence, they are now coming in on a weekly cadence, is the state of our COVID-19 pandemic, our total cases, confirmed COVID-19 hospitalizations and deaths to date. We look at these as a 7-day daily average, and then we look at these as a week-on-week change. And fortunately, those week-on-week changes continue to be green, but we have seen many, many days and weeks where those were red and on the rise. I think our cases, confirmed hospitalizations and deaths, though nowhere near down to where I would like them to be, are lower than we've seen in almost any point during this pandemic. One of the things that we have heard time and time again is how well can we rely on those case numbers? And I think that this is pretty important. This is a graph of testing behaviors, and what we can see, and this is PCR testing behaviors, what we can see in the bar graph over time, time is on the horizontal axis, is that you can see the PCR tests have decreased over time. There was a time during the Omicron phase, that big peak where we were testing about 3 million PCR tests per day. We're now in the 300 to 400,000 PCR tests per day. But they do give us a helpful window in terms of trends. One of my favorite quotes from somebody in our incident management team early on is, you don't necessarily need to count all the raindrops to know how hard it's raining. And so I do think that we did make a conscious decision in collaboration with our public health partners as to whether we needed to count every antigen test that was being done, recognizing that antigen tests might quickly replace all of the PCR testing that was done. And there was a lot of discussion about that decision. We do recognize that testing behaviors have changed. This is just as we have scaled down our PCR testing. This is an MMWR that really just looked at antigen testing shift from August 21 to March 22 to see the real scale up of antigen testing, both in the population overall, shown by that dark line at the bottom, as well as among people who are asymptomatic, the lighter line, and then the middle line among people who are symptomatic. So while we are following the case trends, we do fully recognize we're not capturing every raindrop, and that that we are really using those cases to capture trends. So what I thought I might do is just sort of bring you into the rise of Omicron and rewind to what was literally Thanksgiving Day. We had all been working very hard, all sort of looking for that break. And my oven mitts were on, and I was really trying to put my phone aside. And I was about to take the turkey out of the oven, and I got about 6 calls from the White House. And so the time was not to have turkey, of course. The time was really to discuss that there was a new variant in South Africa that was prompting potential restrictions to international travel. Literally, it was Thanksgiving Day that we were first hearing about this. It was coming over Twitter. It was quickly being classified as the Omicron variant of concern by the WHO by the next day. And we were on the phone with colleagues from South Africa. And one of the great gifts of science is how those colleagues bridge international borders and time, space, and pathogen. And so colleagues that I had literally worked with in HIV for decades, now we were on the phone with on Thanksgiving talking about Omicron. So these were some of the data that were coming out of South Africa. And you can see if you just map these different waves in days shown on the vertical axis and then, on the horizontal axis, and the number of cases of COVID-19 on the vertical axis, you see what was happening with Omicron was very different from these other waves, the alpha wave, the beta wave, their delta wave. And what you could see is this massive, steep rise, very quick rise in cases that was happening with Omicron. South Africa was the first to detect the variant, although it may very well have been present in other neighboring countries that didn't have the capacity to genotype or to genomic sequence. And what was also quickly becoming available were data from the UK, which was also following this variant before we had it, demonstrating that household transmission from Omicron was about 3.2 times that of what was happening or what had happened with Delta. And that early preliminary findings from numerous sources were suggesting that Omicron had a transmission advantage compared to Delta. So we have what we call a variant playbook. And every time a new variant emerges, one of the questions that we ask is it more severe? Who is it more severe in? How do our diagnostics work? How do our medical countermeasures work? How do our vaccines work? So just at Thanksgiving time, around this time, was when we were first launching our Center for Forecasting and Outbreak Analytics. This was a center that was formally launched at the White House last April, but we were starting to gather a lean and mighty team led by Mark Lipsitch and Dylan George, where this center was really had the mission of generating forecasts and analyses to support outbreak preparedness, understanding communicating the model results and the needs that decision makers had in the moment, just when we saw that there might be an impending new variant, and then to support research and development to improve outbreak and forecast analyses. So among the first teams that we engaged with was our CFA team. And we asked them a couple of questions about how this could go. These are sensitivity analyses modeling what could happen with available data from both South Africa and the UK. Now, the four boxes represent two different 2x2 analysis of 2 different parameters: transmissibility and immune escape. Those are inherent to this new variant, to the Omicron variant. How were they going to impact what happened and how many cases we were going to have over time? And what you can see is high transmissibility, high escape in the upper left-hand box, low transmissibility, high escape in the lower left-hand box, and then low escape in the 2 boxes on the right. What you can also see here is a sensitivity analysis on what happens with regard to how we respond. What happens with our mitigation response, as well as whether we can use our boosting mechanisms, if we can boost people fast enough in order to try and avert a major Omicron wave. And I think, unfortunately, you can see in these slides that the high the transmissibility and immune escape were very much more dictating what was going to happen with this variant than our mitigation and our boosting efforts. Although you can see the curve shift downward and to the right if we were able to do more with mitigation, if we were able to do more with boosting. So this was one of the early insights that our CFA modeling allowed us to demonstrate. But given that our data were starting to emerge that we may have high transmissibility and high immune escape, we were anticipating a pretty large wave that was really at our feet. One of the other things that was starting to come clear from our UK colleagues and really the Gauteng province, these are data from the Gauteng province, is this decoupling of cases from hospitalizations and deaths from Omicron. So if you look at these different waves that happen, wave 2, wave 3, the initial wave, wave 2, and wave 3, you see that these peaks of cases shown in blue, hospitalizations shown in green, and deaths shown in orange look like they're essentially mirroring one another. And yet what was happening with Omicron early on is you could see this massive number of cases, a high number of hospitalizations, although certainly not the same magnitude as cases, and an even lower magnitude in terms of the number of deaths. So that was what we were learning in real time, week after week, as we had scientific calls on Sunday morning at 8 o'clock with our South Africa colleagues. Here is how we in the United States were mapping our Omicron variant. We had our first case that was documented. I remember I was in the White House at the time. There was a live press briefing on December 1st of 2021. And for the week, you can see this massive rise. So if Delta variants are shown in orange and Omicron variants are shown in purple, you can see this massive speedy rise in the number of variants, the proportion of variants that were Omicron, such just in that single month period of time, we were over or about 90%, 95% of our variants being Omicron. Again, one of the questions that kept coming up and kept being asked of us is, will Omicron be more severe? And controlling for that and understanding that was a really tricky question. I had the great benefit of calling again on our CFA colleagues, again, the small and mighty team, to try and scope the landscape for how we were going to answer that question with data across the United States. Now, one of the first questions is, especially in that period of time, in that December period of time, we didn't have real-time genomic sequencing of every patient in the United States. And so some were doing analyses that said, well, if it's over 50% of patients in a region or of sequences in a region, we'll call that mostly Omicron. But we did leverage the Kaiser Permanente Southern California health system because it was a closed system and because they were using the TAC PCR. And because they were using the TAC PCR, they could distinguish S gene target failure from non-S gene target failure. And this was sort of our poor man's way of distinguishing between the Delta variant and the Omicron variant. So if we could categorize people by S gene target failure or not, we knew which variant they likely had. We did some validation to see how far that would have been off, and it was off less than 10%. The other thing that was nice about the Kaiser Permanente closed system is that we were able to control for a lot of things that were really hard to otherwise control for: age, sex, comorbidity, prior SARS-CoV-2 infection, and prior vaccination. And because this closed system had all of those features, CFA was able to quickly do an analysis in collaboration with the system that really was able to demonstrate the comparisons of Omicron versus Delta, and that demonstrated that there was decreased risk of hospitalization, of symptomatic hospitalization, again, Delta variant is shown in purple here and Omicron in green, of intensive care unit admission, of mechanical ventilation, and of mortality. So given that we were able to control for all of those hard to control for features, that we could distinguish Omicron from Delta, and that we had a closed system, we were feeling better that we were not going to see more severity case for case in Omicron. However, we also recognize that given the volume of the number of cases, we very well may have challenges from a hospital capacity standpoint. Now, I showed this. This is also a slide from that study that is now published, I believe, in Nature Medicine, that has demonstrated the clinical outcomes by hospital length of stay. So the average length of stay, even for Delta, was about 6 days versus 2 days for Omicron. 30% of the Delta hospitalizations were less than 2 days. About 85% of the Omicron hospitalizations were less than 2 days. So again, another one of those questions that you have a new variant, how are we going to tell whether it's more severe? And we were doing the analyses to understand whether it was more severe. The next question, of course, is how well do our vaccines work? This has been, we have a massive spreadsheet of our vaccine effectiveness studies and platforms, but let me just give you a sense of all of these studies and platforms that we have. So we have the COVIDnet studies. These are hospitalized patients, all ages, and you can see the distribution across the United States. We have the IV study. These are hospitalized patients among those 18 and older. We have the Vision platform, which is ED visit, urgent care, and hospitalizations across all ages, again, different sites. The Heroes Recover study is a healthcare worker study. These are frontline workers, and they engage in asymptomatic screening, again, in numerous areas across the United States. And then finally, the Overcoming COVID-19 platform. These are hospitalized inpatients. These are children, however. So it is a combination of these platforms, not any singular one, that helps give us an understanding of how these vaccines are working. And as soon as we had Omicron, we had the question, how well will our vaccines work? So these were some of our first data looking at vaccine effectiveness against ED visits and urgent care visits that were coming out of Delta. And this was, again, during the Delta period. This was our Vision platform. And we could see the vaccine effectiveness less than 6 months after dose 2, this is sort of early days, was about 86%. Greater than 6 months, we saw some waning down to 76%. And then after that third dose, this was sort of motivation for the booster dose, we saw a bolstering of that vaccine effectiveness against ED visits and urgent care visits up to 94%. Here then is the data that emerged after Omicron. We saw Omicron had less, that everything was less. So essentially, we saw that if you only had 2 doses, even if you were less than 6 months out, your VE against Omicron was about 52%. Greater than 6 months, it waned even more, down to 38%. But after that third dose, you actually got a really robust rebound of your vaccine effectiveness up to 82%. And this was really important information to say, yes, in an era of Omicron, it is really important to get that booster dose. Now, this is VE against emergency department visits and urgent care centers. Everything shifts up a little bit. Again, same platform, Vision platform, when our VE is looking at hospitalizations. It performs better against Delta. It performs a little bit better against Omicron. You see that waning after the second dose down to 57%. And again, data here after that third dose with Omicron, you could get up to 90% protection against hospitalization with that third dose. You know, some of the denominator data have been hard to understand and hard to wrap our head around. I think that this is actually an important, an important slide to convey. And that is, how are we doing with our hospitalizations with our third booster dose? This is now December of 2021. So what we could say is, among those over the age of 65, people over the age of 65 who were unvaccinated represented 12% of the population, but 54% of people who were in the hospital. Similarly, people who were boosted and over the age of 65 represented 57% of the general population and only 8% of people who were hospitalized. So this slide both acknowledges that there are people who are going to be over the age of 65 who are boosted and who are going to get hospitalized, those 8%, but they're disproportional to the fraction of people in the population. And that was really what we were trying to convey. So, one of the things that had been so challenging, and one of the lessons that I have learned is that that policy and action do not spare the holidays. So literally, we went from Thanksgiving to Christmas in really a 3 to 4 week period of time, and we were seeing this massive scale up of cases. We were anticipating a rapid, substantial surge in cases, comparatively lower hospitalizations, but a large absolute number of hospitalizations. We were expecting Omicron transmission to be higher, that it may evade immunity with regard to infection, and that our VE against infection was probably going to be down. Excuse me. We also understood that for all other variants anyway, and we didn't have definitive data from the Omicron variant, but for all other variants, most of SARS-CoV-2 transmission was occurring in the day to two before people had symptoms and 2 to 3 days after symptoms. We didn't have reason to think Omicron would be different, but we did want to acknowledge we didn't have full line of sight of that. So as we were looking at periods of infectiousness and we were needing to understand and create potentially new policy around isolation and quarantine, and we'll talk about that in a minute, we were looking at this period of infectiousness. If you sort of could perfectly isolate when your symptom onset is and call it day 0, the period of infectiousness was somewhere around day -2 to perhaps day 7 or so, that we knew that PCRs and viral loads had a tail, that all of those viral loads in that tail were probably not infectious, that we were picking up some viral particles. We also knew that people were testing at different times, and that if you sort of define your symptoms and define your test as, well, I tested a day or 2 after my symptoms started, or I tested the exact same day that my symptoms started, that you had some actually fluidity in that day 0 of a positive test. And we had to acknowledge that. And that probably most infectiousness happened before the end of day 5, acknowledging also that not all infectiousness happened before day 5 was over. But we had to acknowledge there is like this uncertainty that is happening in this period, and that probably extends to this period as well. But the thing that was happening that was really a challenge at the time was what was going on in the real world. And I'd be curious as to how you and your hospital system felt the impact of this. I was hearing, as I was canvassing colleagues across the country, that pharmacies couldn't dispense insulin because they had too many pharmacists that were out. They actually had to close the pharmacy counters. I heard that blood culture bottles were not reaching major medical centers because of transportation issues, because too much of transportation was out. I had heard that dialysate was actually not reaching dialysis centers because FedEx was out. And so we were starting to see not just a crumble of commercial and industry, we were seeing a crumble of hospitals, healthcare delivery, and healthcare facilities facing staffing shortages in all areas, because so many people were now becoming symptomatic with Omicron, and that we really did need to figure out how we were going to adjust our policies for the moment. We were also starting to see that decoupling of what we saw in Gauteng province in South Africa. Very early on in January, around Christmas, we saw our cases skyrocketing, certainly our hospitalizations going up and our deaths going up, but not at the rate that our cases were going up. The reason I think this slide is so potent is you can really see that decoupling, but you can also see that the hospital admissions in January of 2022 was already higher than it was for our Delta wave in the summer. And so you really see this nice decoupling, but also how this massive number of cases was going to lead to challenges in both hospitals, hospitalizations, and a rise in the number of deaths. So we felt that it was important to be relevant to the moment and to say that we needed to change our isolation and quarantine guidance to a harm reduction scenario where we needed people to isolate during the period of time where they were most infectious, and then to potentially leave isolation and wear a mask for that final 5 days when they were likely, potentially might have some harboring virus, likely much less than that minus day 2 to day 3. But if they needed to, that they could leave isolation. We similarly had, because so many people were needing to quarantine, we wanted to make sure that people were quarantining during the most at-risk period of time, that 5 days after exposure, rather than having people out for 14 days when they were likely at less risk after that 5 days, but again, wearing a mask to mitigate that risk. And that was the motivation really for the change in the guidance at the time. And ultimately, you can see what happened during our Omicron wave here, the decoupling of our cases, our hospital admissions and deaths. And ultimately, you can see even during the Omicron wave, our hospitalizations peaked higher than our Delta wave, as well as during our Alpha wave. Now, one of the things that this also begged the question of is, are we measuring the right things as we think about moving forward? What should be the policy now that we have such an infectious variant, and also that we know that we may have many more infections than we are capturing, especially as we are testing more and more using antigen testing. So we were motivated to refocus not just on transmission, but on community burden. We recognize that there was a current level of high population immunity. This is now dialing us back to about February or March of 2022, that there was high population immunity. Many people had been vaccinated, many people had had recent infections, many people had prior protection and boosting, that elimination of transmission was not going to be possible, that we had evolution of testing strategies, including at-home and point-of-care tests. This was just as our MMWR was coming out on this issue that I highlighted earlier, and that our focus shouldn't necessarily be on the number of cases we have, but on minimizing COVID-19 impact on health and society. What we really wanted to make sure is that we were preventing medically significant illness, that we were minimizing burden on the healthcare system, that our healthcare system could be functional, and that we were protecting the most vulnerable. So previously, you may recall, we had a transmission parameters. We had transmission indicators that were informing all of our public health guidance, including our school opening guidance, our congregate setting guidance, many other guidances, where the goal at the time was to limit transmission, not to prevent severe disease. Of course, we would also like to limit transmission as well. But this neither reflected healthcare burden nor medically significant disease. It was largely driven by an absolute number of cases without a differentiation of those mild to severe cases, and also without a recognition that we were no longer capturing all those cases well because so much was happening in antigen testing. And so what we've opted to pivot for, what we did opt to pivot to, was capturing COVID-19 community levels. We wanted to certainly have cases inform it, and that you can see on that left-hand border, fewer than 200 per 100,000, but also 200 per 100,000 in the last 7 days, but also have it informed by new admissions per 100,000, by staffed inpatient beds occupied by COVID-19 patients. And among the things, as we were thinking about what are the most important parameters to inform these COVID-19 community levels from a policy level, when should we be really worried in that orange level, when our hospitals are full, when our beds are occupied with COVID patients. And we really looked at several criteria. We wanted, first of all, given that this was going to be national policy, we needed data that were available at the county level or allocated to the county level to inform health service area. This was really important. People have asked why we didn't use wastewater here, and one of the reasons is because we didn't have wastewater representation from all of our jurisdictions. We needed data that reflect medically significant disease and healthcare burden, and we needed data that were reported at least weekly so that we could have a timely update to inform our decisions in real time. We did consider several other indicators, as I just mentioned. National syndromic surveillance would have been a great one. This represents only 71% of our emergency departments. We are working to scale that up because it is so keenly important. But at the time, we didn't have national, and we still don't have national syndromic surveillance for all of our emergency departments. Wastewater, we'll talk about in a few minutes, but we only at the time had about 600 sites reporting. It excluded communities on septic systems. It excluded the entire state of Alaska, for example. And then death rates. Certainly death rates are clearly an important barometer for us to measure. It was a lagging indicator when it's a rare event in a jurisdiction. Sometimes those data are delayed. Sometimes those data are unstable at the county level. And so that was among the reasons that we didn't pick that indicator. I have given numerous presentations like this, presenting this map. This is among the nicest it's ever looked, but we still are watching areas in the Northeast, for example. We watch not just the stagnant map, but of course the percent change in the trends. You can see we have about 2% of our counties now that are at high, about 18% that are medium, and about 80% that are low. And on our website, we have not only recommendations for jurisdictions, like if you are in a high county, we do recommend those jurisdictions implement masking policies, but also recommendations at an individual level. If you are living in a county that is high, you may want to put on your mask at that period of time. If you're immunocompromised and you're living in a county that's medium, you may want to also put on your mask. Then you may want to use antigen tests more liberally, or have your visitors use those antigen tests more liberally. I do want to say that we on our website keep an active map of our COVID-19 community levels, and these are the COVID-19 community transmission. Sorry, our COVID-19 community transmission. These are the levels we're asking our healthcare workers and our healthcare facilities to look at in terms of their masking policies, recognizing that we do need a higher bar because transmission in lack of transmission in our healthcare facilities is so very important. And so we still on our website have both of these maps that we keep active all the time. So, in the big picture, the framework for our monitoring prevention was this middle piece, which is the COVID-19 community levels, which really should, at least in our mind, inform prevention measures like masking, like testing, like community level strategies. We also recognize that COVID-19 vaccine coverage in this upper left-hand corner is really important, keeping people up to date, getting their bivalent vaccine, and that vaccination coverage very much has a lot to do with how full your hospitals are going to be, how many cases you may have, and that things also need to be informed at the local level. Is there going to be data from wastewater surveillance? How are we doing from a health equity standpoint? Is there going to be a major convention that is convening in that jurisdiction? And all of this coming together should help inform local vaccine outreach and distribution, prevention measures, as well as local policy decisions. I will also note that we have since updated our COVID-19 isolation and quarantine policies, yet again, recognizing that our vaccine effectiveness is not working as well necessarily against infection as it had against urgent care visits and hospitalizations, it's still working well, but less well. We also recognize the increased use of antigen tests and how many people are interested in using those antigen tests to leave isolation. And that many people now, so many people, especially in schools, especially in other places, are exposed to, potentially exposed to Omicron, to circulating variants, and that we are asking people, instead of staying home to quarantine, to mask for 10 days. So what I thought I would do now is to just tell you where we are in the current phase and monitoring variants. And for those of you who feel like it's alphabet soup out there, well, there's a good reason for it. And that is because this is what our, one picture of what our variant mapping looks like right now. And there are a lot of sub-Omicron variants that are emerging and converging, actually, in terms of evolution. What's different in this moment is that nearly all of these are sub-variants of Omicron itself. We saw massive waves after Alpha. We saw one with Delta. Those are really new variants, and these are all single mutations, several mutations that are branching off from either BA2, BA4, or BA5. What I can tell you is we're watching these mutations carefully. You can see several of them appear frequently, this R346T. You see it in numerous pathways, this converging evolution. One of the reasons that we are concerned about that 346T is because of its resistance to Evusheld. And so you see that in numerous pathways. It's also interesting to follow where these come off, where these branch off, as we have a bivalent vaccine now that targets both the wild type as well as BA4 or BA5. We may expect more robust immunity against variants that, or subvariants that emerge from the BA4, BA5 lineage than perhaps from the BA2 lineage. So with that, I will show you that this is where our variant map looks like right now. BA5 is now all of those big, tall green bars. And we're watching very carefully BQ1 and BQ11. I'll remind you that BQ11 is with the little poop icon there. And that is because we are following these very carefully, and those are of our greatest concern right now. Both for the number of mutations, but also for the impact and the phenotype that we are worried that they may imply. So most recently, and these come out every week on Thursday, we are now casting about BQ1 being about 9.4%, BQ11 at about 7.2%. Again, early on with relatively small number of sequences, we have larger confidence intervals just to be aware of. The doubling time of these for both variants compared to BA4 and BA4-6 and BA5 are increased. The doubling time for BQ1 has been about 10 days, for BQ11 about 6 days, and both variants now are expected to have both Evusheld and bebtelovimab resistance. There are no current data, and both of these stem from the BA5 sublineage. There are no current data to suggest decreased vaccine effectiveness, but something we are watching, of course, very carefully. If we look at this by region, we also map our variants by region. You can see it is actually different across the map. In region 2, you can see that about half of our variants are now predicted to potentially, or half of our sequences are predicted to potentially have Evusheld resistance. In region 3 down here, you're probably closer to 60% in your region. Region 10, only about 25%. So again, something we focus on carefully. And one of the reasons to do this is to sort of say, we still have 350 to 400 deaths every single day. These are data that are up on our CDC website with reference to the 18 to 29-year-olds. When we look at the deaths that are happening by age group, we see a 340-fold increased risk of death among those over the age of 65, 140-fold for those over the age of 75, and even among those 40 to 49, a 10-fold increased risk of death. And so this is the work that we have ahead of us. When we talk about where we are with boosting, there was a lot of work that was done numerous months ago in the spring and early summer, talking about the importance of getting a fourth dose, especially for those who are immunosuppressed, those who are elderly. These are data out of Israel, where you have time since you got your fourth dose compared to the third dose. Well, I should say that the y-axis is the adjusted odds ratio compared to the third dose. And the dots represent VE against infection in blue and against severe disease in orange. Certainly the confidence intervals are wide for severe disease. These, at this point, were relatively, fortunately, rare outcomes. But what you can see is a transient bump in how it can really help you against infection early on and maybe help you for some period of time. But the real benefit of that fourth dose was against severe disease, especially for that elderly population. Here is now how we're really looking at VE across numerous of our platforms. But this is this is a complex graph, so bear with me. The top part of the graph shows VE against the BA2 variant, the bottom against BA4 and BA5. You see 2 doses of vaccine shown in green, 3 doses shown in blue, and 4 doses shown in black. And then what you can see moving down the top box or down the bottom box is what happens with increased time since vaccine. So you can see with your 2 doses of vaccine, you had good VE against, this is against ED and urgent care visits, maybe around 50%, and that waned over time. With the third dose, you got much of that VE back, again, waned over time. With the fourth dose, you again got much of that VE back. In fact, it probably increased even above where it was for second and third doses. And very similar trends for BA4 and BA5. We follow this for 2 doses, for 3 doses, for 4 doses, follow it over time. And now we did that for emergency department visits. This is essentially the same graph, again, followed for hospitalizations. You see that that VE was waning with your third dose. We wanted to bump it up to your fourth dose. Very similar here with BA4 and BA5. So really, we did demonstrate the importance of that fourth dose in waning immunity and protection against the most severe outcomes in, hospitalization, and using the BA4, BA5. We have worked hard, given the heterogeneity of the population out there, both in terms of when they got their last dose, how many doses they have received, to really streamline the recommendations. What we anticipate for this bivalent boost, again, BA4, BA5 bivalent with the wild type strain, is that the effectiveness against severe disease continues to be higher and more sustained over time than effectiveness against infection. That the VE against 4 and 5 predominance was generally comparable to VE was comparable in 4 and 5 compared to 2, and that the third dose provided substantial protection. Coverage with the fourth dose had remained low. And what we're really working to do now is say anybody who has had at least 2 doses should get this bivalent boost, or this bivalent vaccine this season. And we're ideally really pushing before Halloween. You've probably seen more public messaging going out, and I sure hope all of you are, I expect that all of you are with us on this message of the importance of this bivalent vaccine. Just to give you a sense of where we are, we get these vaccine data now weekly, not daily. We see about, if you look at all age groups, about 79% of people have received a primary series. About 49% had received 1 booster before we rolled out our bivalent campaign, and about 7% of people have received a fall booster. So we have work to do. Some cautious optimism here is that we are doing better with our higher risk populations, that we have about 93% with our primary series, about 72% who've gotten the boost, and about 17% with our fall boost. But we do have more work to do there. I do want to talk a little bit about wastewater because this has been really an important new tool. It's not really a new tool. We've been using wastewater a lot in so many public health areas, especially in polio and global polio surveillance. It's nice because it's passive and anonymous. It has inclusive reach. It's actually well accepted by the public. It offers flexibility, timely genomic sequencing. There's a lot of public health support for it. And really this took a rise in through COVID-19. In February of 2022, we had about 204 sites that were doing wastewater. We now have about 984 sites which have the capacity to do wastewater surveillance. And I'm happy to say that we have been able to leverage this during the monkeypox outbreak, for example, where we were able to detect wastewater in 11 Northern California sewer sheds. We've been able to also leverage it for polio. This is a map of New York with vaccine coverage seen in that map. You can see the areas with the lightest coverage are the areas, Rockland County, where we had the polio case and where we have been actively working and doing wastewater surveillance in collaboration with the state of New York. I'll just note that the rate of polio, of vaccine coverage in some of the jurisdictions that we have been measuring is about 67%, so really quite low. Wastewater is not a panacea. I do want to say that we are learning so much about it, and I'm really excited about its potential for the future. We do have to recognize some of its limitations. Decentralized wastewater systems are not going to be captured. We have whole states and whole jurisdictions that are not captured. About 20% of US residencies are not connected to wastewater. We really do need to understand how we interpret the data in a low incidence setting. What happens if you find a pathogen? Is it that it's been there for weeks, or did it just show up and it will disappear tomorrow? Do negative tests indicate an absence of disease or an absence of infection? So we have a lot to learn, and this is probably pathogen specific. We have some barriers to implementation. Many of our public health labs are scaling this up. There are interesting ethical and privacy concerns. There are genetic data that we can collect from wastewater and capacities there that I think are really interesting to dive deeper in. But I suspect that this will be an ever evolving, really important field in infectious diseases, non-infectious diseases, and public health in general. With some remaining time, I thought I would just highlight some of the things that we have been following in monkeypox. This is our monkeypox case curve. I recognize that we had 28,000 cases and just an MMWR that is out today describing some of the severe cases and deaths that have happened. So certainly tragedies that have occurred during this period of time. There's been massive public health action, massive healthcare action, massive partnership. I want to thank you all for it that has happened in those months to be able to bend this curve at the speed that we did. We put out 5 HANs, those are all shown by the red stars, that included the first case on May 17th, the first HAN was on May 20th, updated case finding guidance in June, updated testing and treatment guidance, updates for children and adolescents and pregnant people and those breastfeeding, and then severe manifestations, including among those living with HIV. We also have put out, thanks to our Center for Forecasting and Outbreak Analytics, the technical reports that are shown by these arrows that are akin to sort of the state of the state, really trying to get our science out faster. Those technical reports, we now have used time-varying reproductive numbers that have demonstrated that we have been under 1 for some period of time. We have been slowing the growth of the outbreak, which is also terrific. And a lot of the projections of what could happen if we don't kind of keep our eye on the ball. So much of this has been related, we acknowledge, to education, to vaccination, to behavior change, and of course, to some increase in immunity in the population. We are continuing, we have an active monkeypox response. We continue to meet several times a week, and that science is continuing to evolve. And part of that is because of our data related to equity. You can see in this graph White population infections are shown in blue, Black or African American in purple, Hispanic in green. And you can just see, as with so many infectious diseases, how things evolve to more racial and ethnic diverse communities, more Black and brown communities over time, like with so many things in infectious diseases. We have a lot of work to do here. One of the areas, so if you were to say grossly, just by looking at that our population now is down to about a third African American, a third Hispanic, and a third Black, a third white. We do have work to do in terms of how we're doing with our Jynneos vaccination. We have increased our Jynneos vaccination that has been received by both the Hispanic community and the Black community, but those are not the rough thirds that I just outlined in the prior slide. So we have a lot of work to do in public health, in healthcare, and communities in reaching our harder to reach populations to make sure that they too are protected against monkeypox. I'm looking at the time. I want to spend just a minute to talk about Ebola, as I recognize you all are a critical partner in our Ebola activities. The first case of the Ebola Sudan virus, not Zaire virus, the Ebola Sudan virus was first detected, confirmed on September 20th. Although some concern that it had been circulating beforehand. We now have outbreaks reported in 7 districts, including, in Kampala, for a total of 110 cases. 110 cases, 90 confirmed, 20 probable, and 48 deaths. I am really proud of the work that we are doing on CDC. I was at, I had the great privilege of being at the Congo-Uganda border in this photo, hearing about the important work we are doing in a global health securities, One Health, One CDC response. And just to acknowledge that we have a team of CDC of about 140 people, a country office of about 140 people. We now have over 20 people on the ground engaged in this response. And so much of the work that we do at CDC in partnership with public health, in partnership with healthcare, in partnership with our partners around the world, through the leadership of Uganda and the Ministry of Health in Uganda, is for global health security, for Ebola Sudan, and for all infectious threats around the world. So with that, I will just close here by saying we are in a different phase of this pandemic. We observed in real time a decoupling of cases of severe disease. There are still, in my mind, far too many Americans that are dying of COVID, partially due to low vaccine, low booster uptake. If I have learned one thing in my last 2 years in this role, almost 2 years in this role, is that I don't necessarily know which infectious or non-infectious threat will be the one that comes knocking on our door, and that it's so critically important that we have a robust public health and healthcare infrastructure working in partnership to address whatever may come next. As science evolves, we have to adapt our guidance and our recommendations to balance safety and effectiveness of all interventions, that health clearly has to be an important seat at the table, and that we need to sort of have that seat be informed by epidemiology, by basic science, and by real world applications. We in public health strive to be data-driven, action-oriented, timely, and most of all, good partners for all of you. So again, a great pleasure to give this talk, and thank you very, very much.
Thank you very much, Dr. Walensky. That was absolutely fantastic. Thank you for that wonderful talk. I wish you can hear the virtual applause, but I know it's resounding. We've received several questions. We don't have much time, so forgive me since we're not going to be able to handle all questions. They are fantastic, but I think you maybe have time for 1 or 2 questions.
Yeah, please.
Yeah, so the first question I'll pose to you was submitted by one of our ID fellows, Maria Geba. And I think it has a lot of insight and challenging on a couple different things, and I'll sort of expand the question. And the question essentially is, how do we perform research on novel viruses like SARS-CoV-2, particularly looking, I think somewhat controversially, I think it's been labeled as gain of function mutants, particularly with the recent work that was done at Boston University.
how do we communicate, or how do we put safeguards around that research? And I think the second part is with those safeguards, how do we describe that to the lay public who have concerns about viral escape?
Yeah, I wish I had an answer, a wholehearted answer to that question. This is going to be one of our challenges moving forward. And I think that I know that NIH is looking at this because of what was raised with the research that was happening at BU. But I actually think we have to find the path to be able to do this, to be able to not only conduct the important research to answer the important questions and to communicate it. And maybe what I will do is pivot and say, some of this is really about the communication of said research. And some of this is really about the politicization of gain of function research in general. I can tell you I've testified now more than a dozen times on the Hill. Almost, I can say every time that question has been posed to Dr. Fauci, I'm sitting to his right. We've had numerous conversations about how when those things get picked up by the media, when those things are the focus, we're losing the importance of the insight, the scientific insight, the medical countermeasures that could be learned and gained, right? All of the things that could be learned and gained. So I don't actually have the answer. I know that there are large committees that are looking at this really important question. I don't think it's been helped by the moment in terms of the politicization of where we are.
Okay. Well, I think with that, we're at the top of the hour. So thank you once again, Dr. Walensky. It's been just an honor and a pleasure to have you present today. It's a fantastic talk. So thank you once again. Justin.
Absolutely. Thank you so much, Dr. Walensky. Thanks to the whole CDC team for helping to make this happen. Thanks to Dr. Sifri as well as Dr. Fred Hayden for their ongoing leadership with the Hayden Farr Lecture in Virology and Epidemiology. Thanks to our participants, and please stay tuned for announcements for future medical center hours in the months to come. Have a great week.